Today we'll be discussing about chronic myeloid leukemia. So before that, before we get into the topic, let's see the basics first of all. So how does chronic myeloid leukemia arise? You see the hematopoietic 3D positive stem cells are there, right? It gives off two main lineages. One is the myeloid lineage, another one is the lymphoid lineage, okay? From the myeloid comes the RBCs, the granulocytes, the monocytes, and the megakaryocytes. From the lymphoids come the B lymphocytes and the T lymphocytes, okay? So what happens is when there's accumulation of the immature myeloid cells, okay? When there's the accumulation of precursors of myeloid lineage, that is the erythroblast, myeloblast, or the myeloid stem cells, that causes acute myeloid leukemia, okay? At the same time, when there's immature increase of or accumulation of lymphoid stem cells, that leads to acute lymphoid leukemia. So acutes are caused due to immature cells, okay? Acutes will cause is caused by immature cells, and the chronic myeloid leukemia is caused when the mature cells are increased in number. For example, if there's an increase in RBCs, that leads to polycythemia vera, and when there's increase in the myeloblast or the granulocytes, it leads to chronic myeloid leukemia. And so yeah, what is chronic myeloid leukemia? Chronic myeloid leukemia, first of all, how is it caused? Every cancer is caused due to a mutation in a gene, right? The mutation in the gene is because of the tyrosine kinase mutation, which leads to Philadelphia chromosome. Okay, what is Philadelphia chromosome? It is the translocation of the 9th chromosome and the 22nd chromosome. Okay, so what happens is, in a normal 9th chromosome gene, that's the ABL gene. Okay, this ABL gene gives rise to tyrosine kinase, and the BCR gene is present in the 22nd chromosome. Okay, that hyperactivates anything. So what happens, this part goes over here and this part comes over here. When it moves to the 22nd chromosome, the BCR gene and the ABL gene together fuses and causing the Philadelphia chromosome. Okay, what happens when the Philadelphia chromosome is present? There is tyrosine kinase activity, okay, and it is increased drastically because of the BCR gene, and that leads to overproduction of the neoplastic cells. Okay, so for this specifically, a drug is produced, that is the imatinib. Imatinib inhibits this tyrosine kinase receptor. Okay, so yeah, and as we know, the cell of origin is the hematopoietic stem cells, and the causes are actually not known, but it is observed in radiation therapies. So what is the clinical findings? We can see that the male to female ratio is 1.3:1, and the common ages is 50 to 60 years old. The most common presentation of chronic myeloid leukemia is massive splenomegaly. See, if you see the CT scan, this is the right hand side, okay, this is the left hand side. Over here, this is the liver. Liver is the largest organ, I believe, but if you see it here, you see the spleen compared to the liver, it's actually more bigger, which is massive splenomegaly. Why is that caused? That is caused due to extensive extramedullary hematopoiesis. That is because in chronic myeloid leukemia, these granulocytes increase drastically. But with that, RBCs also increase, all these cells increase, which goes and takes rest in the spleen. Okay, that causes splenomegaly. Okay, hepatomegaly is observed and lymphadenopathy is also observed sometimes. So when we see in a blood count, I mean when we ask for a blood count, we see increased hemoglobins, increased total leukocyte count. Yeah, see in increased total leukocyte count, it is between 25,000 to 2 lakhs. It's like in the lakhs region. Okay, why is that? In an infection also total leukocyte count increases, but it increases up to 30,000 only. It doesn't increases into the lakhs and all. In chronic myeloid leukemia only it enters the lakhs. Okay, so there's increase in neutrophils, increase in monocytes, increase in basophils. Basophils basophils is usually increased during allergies only. Okay, it doesn't increase in infection, and uh, and that is one characteristic feature. Only if that person is undergoing an allergy it should increase normally, but he's not having an allergy, he is having a chronic myeloid leukemia, and this is one of the characteristic features. Eosinophils and RBCs, everything is going to increase in the myeloid lineage. Okay, if we see the blood presentation, we will see a garden party appearance. Party, okay. Why is that actually called? Why is it called a garden party appearance? You see over here, there's these RBCs, and then these basophils, and then these myelocytes, and then the band forms of cells and neutrophils. Wow, there's a lot of varieties, right? And here you can see all these tiny platelets also. So as you can see, there are various types of cells over here. And in a garden party, what happens is a lot of people come to a garden party wearing different costumes. It's usually a trend in the United States of America. And you can see all these nice different dressed people. So it resembles that, right? There are a lot of cells over here. So yeah, that is garden party appearance. And then, okay, see, you're a doctor, and then you're in the ER or in your clinic, and a patient shows up. He shows up with all these high temperatures, dragging in the left side because of that massive splenomegaly and all that. It kind of resembles that the patient is having fever, I mean, or a viral infection. But how do you differentiate that? That you can do it by the lab score. What is lab? Everything we are going to go into the basics. Lab means leukocyte alkaline phosphatase. You see, this lab is required to fight infections, but in CML there are no infections, right? Therefore lab score is decreased only. Lab score is increased in a leukemia reaction, aka acute infections, something like that. Yeah, so yeah, okay, you see that the lab score is decreased, so you kind of have an idea that okay, this could be CML. Then you go for the confirmatory tests, that is the gene karyotyping, PCRs, and the FISH test. You can't directly go into these tests, these are expensive. Okay, that is why lab score is used. And with all of this, the most important is the FISH test. In FISH test, what happens is it is fluorescence in situ hybridization. What is that? We add fluorescent agents into the chromosomes and observe it. You see, in the 22nd chromosome, we add the green color, fluorescent color. Okay, and in the 9th chromosome, we add the pink color. When it combines, the BCR-ABL fusion occurs. It causes these yellow colors, as you can see over here, right? That shows okay. There's BCR-ABL fusion, which means Philadelphia chromosome. Chronic myeloid leukemia, done. Your diagnosis is done. Okay. Now, in chronic myeloid leukemia, there are certain phases. Every leukemia has a phase. Okay, and CML is one of the most common leukemias. So it's divided into the chronic stage, accelerated, and the blast phase. Okay. In the chronic stage, the blast cells percentage is 0 to 9%, and accelerated is 10 to 19, and in blast it's greater than 20%. You see this? This is somewhat similar to acute leukemia, right? In acute leukemia also, the blast cell percentage is greater than 20%. So yeah. And basophils normal range is actually 0 to 2%. It only increases during an allergic reaction, but in chronic phases it's 0 to 19%, and in accelerated phase it's greater than 20%. The other characteristic features are, see, the chronic phase, it happens for 2 to 6 years, and the patient has an enlarged spleen, larged, past tense, okay. And in accelerated phase, what happens is, platelet counts may fluctuate. It may increase or it may decrease. And then the spleen size is increasing, present tense. It is increasing, and in chronic phase, it was increased. This increasing shows that this has gone into another stage, and cells are actually being more produced, and it's going into a bad side. So therefore, the spleen, the spleen continues to enlarge. That's bad, right? That's very, very bad actually. So yeah, and with that, it gives rise to a lot of cytogenetic problems like trisomy 8 and duplication of the Philadelphia chromosome itself. So there are lots of other gene abnormalities occurring, and the blast phase is one of the worst. It's really bad, and the lymphoblast cell count is greater or equal to 1% over here. And in accelerated phase, there is no response of the tyrosine kinase inhibitor, aka imatinib. Okay, so yeah, what are the complications? The patients may also show up with hyperuricemia and gout. Why is that? You know it, because there are more cells produced, right? More cell produced means it requires more cells to be degraded, right? More cells produced means more cells have to be degraded. So when more cells are degraded, there's more nucleic acids being released during degradation. Nucleic acid means nucleic acids had purines and pyrimidines. This purine, when it undergoes metabolism, it produces urea, and that kind of deposits in the blood and causes hyperuricemia, and that uric acid goes and goes into those joint cavities or joints and accumulates over there, causing gout and all. So yeah, what are the treatments? The treatments are imatinib, as we know, and a combination of imatinib and IFN alpha and hydroxyurea. Hydroxyurea is actually an inhibitor of the S phase of the cell cycle. You know that as G1, G2, M, S phase and all, right? So this inhibits the S phase, that is the DNA synthesizing phase. And then bone marrow transplantation is acceptable in certain individuals again. So what are the varieties? Varieties is the juvenile myelomonocytic leukemia. For this, bone marrow transplantation is done because the patient is young and like less than 4 years old, so there's not a lot of bone marrow to replace, so not a problem. Whereas in a 50 or 60-year-old, she or he has already lived their life, and we would much rather undergo some other treatment. And then there's chronic myelomonocytic leukemia, where there's no basophilia and eosinophilia, one of the characteristics. And there's chronic eosinophilic leukemia, as the name suggests, there's increase in the eosinophilic count. And chronic neutrophilic leukemia, and this neutrophils drastically increase. And there's granulocytic sarcoma, soft tissue masses composed of sheets of leukemic cells. Right, so this is chronic myeloid leukemia for you. Thanks for watching, and make sure you like, you share it with your classmates, and let me know in the comments, how was it? Was it a different experience? I mean, this is my first time using something like a screen and writing it down and explaining it to you. Do you like it? And let me know any doubts, or you want any other topic specifically for me to teach. So yeah, and thanks for watching. And as always, be awesome. Ta-da.